one of the things we're seeing is a lot of NPs that are leaving primary care, which is where the basis of our education was, and moving into specialty practices. And that's awesome because the demand is there and NPs do great jobs. But you need to be able to support that scope of practice. And in my state, my scope is you must be able to defend experientially and educationally the work that you're doing. So when I became an NP, I didn't learn how to round in a hospital. It wasn't in my education, but I spent years alongside a physician, learned how to do that hospital-based work, and then worked in that setting for a very long time. Today, a lot of the large facilities are saying, if you're going to work in a hospital, we don't want a family NP. What we want is an acute care NP. So I say to the NPs that are on this call, who are being asked to do things like, or wanting to do things like aesthetics and IV rehydration and vitamin infusions, is that in your scope? And can you defend that educationally and experientially? I think there are a lot of places that you can't. And so I testified in a very large malpractice case, and the whole impetus of that case was a family NP working in a rural ER, and should that NP have been there? So I bring that up because I think that that is a very big issue that we need to think about. And so I have been in my own clinic now for 18 years. I'm in a full practice authority state, but you know what? My liability, I don't think it's any higher in my own clinic or in a full practice authority state, because I always treated those patients the way I thought that the standard of care demanded. And I collaborated with a physician when I needed to, but I'd still do that even in a full practice authority state. None of us work in a silo. And just because you have a supervisor or a collaborator doesn't change your liability. You still have liability. You're at risk with any patient that we take care of.